Pass the floor to Feridun. Thank you. I would like to thank the organizers for giving me this opportunity. I today will be talking about a rather thorny issue, ECT in pregnant patients. This much we know. If during pregnancy, if you do not treat a psychological condition, then there are complications regarding many different areas. And because of depression and anxiety, there are pregnancy and delivery complications. Neonatal health is impaired. There is preterm delivery, and there's impaired development in the womb. That's why we need to treat everything that we observe during pregnancy, because distress has an impact on endocrinological system and renders the patient susceptible to side effects. The most common psychiatric disease during pregnancy is depression. In developed countries, 7 to 15% of all pregnant women suffer from depression. In developing countries, this percentage is between 19 to 25. Prevalence is elevated during the first and third trimester, and these are observed less in the second trimester, it is said. But based on our study, I can say that we saw more of these incidents during the second trimester. Women that have a depression history suffer from a relapse during pregnancy. So when they're on remission, when they're not on medication, half of these patients experience relapses. And some of these patients are maybe on treatment, and because of pregnancy they may have to discontinue their medication, and when that is the case, 70% of the patients during the first trimester become ill again, and 1/3 of the pregnant women are diagnosed with depression for the first time during pregnancy. For bipolar disorder 1 and 2 group patients, 70% of the patients develop a mood episode during pregnancy. Manic depressive or mixed episodes are observed. Anxiety disorders have a negative impact on fetal development, and in anxious mothers, neuroendocrine system is overfunctional, and this has a negative impact on the health of the fetus, and many anxiety patients may observe preterm deliveries. Obsessive compulsive disorder. During pregnancy, there is deterioration in symptoms, and in certain publications we see that OCD symptoms are deteriorated because of pregnancy, but there are other studies that say the opposite. Some people say that because of pregnancy, panic attacks, for instance, decreased in some patients, but Cohen and his colleagues actually demonstrated the exact opposite. So in the past, and in certain parts of Turkey as well, people think that pregnancy is a panacea for psychiatric diseases, but actually contemporary wisdom suggests that this is not the case. During pregnancy, treatment of psychiatric diseases is not easy, because during the treatment, the psychiatrists need to work with obstetricians, and during pregnancy we lack some studies, and both the psychiatrists and obstetricians find it difficult to treat patients during pregnancy. Now, let me tell you why we find it difficult to treat patients that are pregnant. Naprotilin B category is one of the categories. The other SNRIs and SSRIs are in this category C. Paroxetine has been regressed to category D. Amitriptyline, imipramine, and reboxetine are also in the D category, not recommended for pregnancy. And for category C, you need to look at the balance of advantages and disadvantages. As for the atypicals, they're in C category, and as for mood modifiers or regulators, lithium is category D, carbamazepine is category C. Anxiolytics, these are all in category D. Clonazepam was thought to be safe during pregnancy, but the latest studies reveal that all anxiolytics should be in category D. So what do these medications do when administered to a pregnant patient? Antidepressants cause spontaneous abortus, still deaths, stillborns, preterm delivery, and cardiac risks. Antipsychotics cause elevated gestational weight, diabetes, and preterm delivery. As for mood regulators, cardiac septal defect, polyhydramnios, preeclampsia, respiratory distress syndrome, hypotonia, and preterm births. So, because of these side effects, ECT might be a safer option for pregnant patients. There are 57 published articles, and these focus on 339 cases, and an evaluation was made. Only 69 cases data was fully accessed. Response in bipolar disease patients, the response rate is 85% in major depression, 83% in schizophrenia, and schizoaffective 61%. And 24 of these 69% patients, are schizophrenia patients. In 25 out of 339 cases, neonatal and fetal complications are observed, deaths and stillborns. In 18 cases, only one was associated with ECT, and because the mother had developed status epilepticus because of the ECT, and this is directly correlated to ECT. But the others, for the others, cause of death is unknown. Temporary fetal bradycardia or deceleration is also quite seen. This is one of the most commonly seen side effects. Also peritonitis, crossed legs, and preterm delivery, lung cysts, aortic coarctation, congenital blindness, cortical infarct, and mental retardation. And the prevalence of these are the same as the normal population. But still, in 25% of 339 cases, these side effects were seen. Only 11 of these neonatal and fetal complications were associated with ECD. There was one stillborn, and there was a vaginal bleeding in one of the patients. As for maternal complications, most of these are associated with ECD. Again, out of 339 cases, in 20 of the patients, status epilepticus was observed, the baby was stillborn, hematuria, miscarriage, uterine convulsions, and preterm delivery, vaginal bleeding, abdominal pain, and placenta décollement was seen. And 18 of these maternal complications were associated with ECT. This is another compilation. In 300 cases were observed, and 28 of them had complications: temporary fetal arrhythmia, mild vaginal bleeding, abdominal pain, and self-restricting uterine convulsion, which is a serious condition. Your last 5 minutes, please. Ahmet's presentation was quite long, so hopefully I will finish on time. In our publication that was accepted by General Hospital Psychiatry, there were 33 patients, 19 major depression, 12 bipolar, 2 schizophrenia, and we had 12 more bipolar patients, but we excluded them from our list, so we had 33 patients. We based our publication on this. In 21 of these patients, no medication treatment was given to these patients. During pregnancy, only ECT was given to these patients, and these patients were followed up on. And this is why our study was so interesting. 10 of the patients, for 10 of our patients, this was the first pregnancy, for 9, second, for 10, a third, for 4 and more. In 13 patients, we had to administer ECT during the first trimester, 15 second trimester, 5 patients received ECT during the third trimester. 8 of these patients were diagnosed for the first time during pregnancy. They had no psychiatric history previously. 25 of these patients had psychiatric diagnoses before. For 2 patients, they had ECT history because of psychiatric disorders. Response rate for major depression was 84%. This is similar to other studies. 3 of our patients developed a partial response, and 2 of them had comorbid OCD diagnoses. And in bipolar disorders, response rate was 91%, in schizophrenics 50%, but we only had 2 patients, so we can't come up with generalizations. None of the patients had preterm deliveries. In 3 patients, temporary uterine convulsion was observed, and when we consulted with the obstetrics department, no further action was taken. And this is the birth information for 27 babies. In 24 babies, there was no problem. In 1 baby, there was a congenital dislocation of the hip, and we consulted the orthopedics department, and it was said that a uterine convulsion could not have possibly caused this because of ECT. In 1 of the babies, there was myocardia, and we talked to the pediatricians. This was because tachycardia. We saw the baby when he was 18 months old, and the baby was quite healthy. There was 1 stillborn, and this took place 3 or 4 months after the ECT, but in the literature there is another case of stillborn related to ECT. So conclusions, ECT is a safer option for pregnant patients. It's an effective type of treatment for pregnant patients. This sort of increases or strengthens our hand, but it's very important to follow up on the patients. At first we had some problems regarding ECT on pregnant women, but now if the patients are not on their active if the patients are not in a bad, if their situation is not bad, we can give them